Hi, everyone. I'm Alia Amin. I am the lead for the Cardiovascular Disease and Diabetes Coalition, and I will be just hosting the breakout room today and doing the intro and fielding some questions for all of you. We'll give everyone just another second to hop on before we begin. But while we're waiting for everyone else to join, I will go ahead and welcome our presenter today, Dr. Samantha Averill. Let me just make sure she was able to get in to this session. Yep, here she is.
Hi, sorry guys.
Hi. Oh no, you're totally fine. I was just about to introduce you. Dr. Averill received her Bachelor's of Science in Biology from the University of Kentucky, her medical degree from the University of Louisville School of Medicine, and completed her pediatric training at Indiana University. She is currently a second-year pediatric pulmonology fellow at Indiana University. Clinical interests include severe asthma and the relationships between asthma and allergies and mental health. So with that, I will turn it over to Dr. Averill and take it away. And as I said, if you have questions, please put them in the chat and we will have some time at the end of the session to answer those. So Dr. Averill, all yours.
Thank you. Thanks for that lovely introduction. I'll go ahead and share my screen and we'll get going. Let's see here. Oh, hold on just a second. This looks a little bit different than mine, but we'll go ahead and start there. All right, here we go. All right, are you guys able to see just my slides?
Yes.
Yes. Perfect. All right, well, like was already mentioned, my name is Dr. Samantha Averill. I am a second-year pulmonary fellow, and I'm really excited to talk to you guys today about the social determinants of health and how they affect asthma. I do not have any disclosures. So here I've outlined some questions to help guide us during our discussion. So what are the social determinants of health? What are some real-life examples of social determinants of health? What is Maslow's triangle? How do the social determinants of health affect people with asthma? And what can we do to combat the inequities related to social determinants of health? And my goal today is to really just introduce these topics so that at the end of the day, you're more aware of them and ultimately start considering them in your everyday interactions with asthmatics, and then, offer some strategies that are ongoing to combat some of these things. So I think it's useful to start with, so as we heard earlier so far, asthma is common throughout the population and it's a major contributor to healthcare costs in missed school days. However, we know that certain populations are much more likely to have poor asthma control, and we'll talk about why that might be. But first, I think it's important to define what the social determinants of health are. My slides will probably catch up here in a second. There we go. So the World Health Organization defines social determinants of health as the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. Or in other words, it's the things about our lives that affect our health but are not necessarily genetic or predetermined. Now we've talked about a definition, we can jump into one of our main questions, which is how do social determinants of health affect people with asthma? So we know that asthma affects people differently. We found that asthma disproportionately affects patients who are part of certain racial and ethnic minority groups in lower socioeconomic status and have lower education level. And not only is it more prevalent in these populations, but these patients appear to have more severe asthma symptoms. The bar graph here illustrates that children who are Black or Native American have a higher prevalence and higher rates of asthma attacks compared to their white and Asian counterparts. And sadly, these disparities have persisted over time. So what accounts for the differences we see in these populations? You may think perhaps genetics play a role. And while genetics are undoubtedly affect our health, it's unlikely not the biggest piece of the puzzle. An important concept to keep in mind is that in the United States, race is strongly related to socioeconomic status, which, as we'll see today, strongly relates to our discussion of the social determinants of health. It's likely that a lot of different factors makes these differences that we see visible. The WHO uses this model illustrated here to talk about the social determinants of health. And I think it's a nice visual. And so we'll use it today throughout the talk to organize our thoughts around the social determinants of health. They've created 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and the social community and context. This is the first model I saw when I started thinking about this talk and preparing for it. And I think it covers a lot of aspects of our culture. And each of them are important and interact with each other. Also, while I was preparing, I came across a different model that integrates well into this one. It's called Maslow's hierarchy of needs. So we know that the social determinants of health are directly related to our needs as humans. And this pyramid structure is called Maslow's hierarchy of needs. It was created by Abraham Maslow back in 1943. And it's a psychological structure that has been widely used to describe what motivates or allows humans to achieve their goals and address barriers. The theme is that higher level needs cannot be fully met until lower level basic needs are met. Focusing on this pyramid, we can see that physiological needs like food, water, and shelter are in the base in red and orange. And working up from there are feelings of safety, belonging, and accomplishment. These are all required to reach our goals and thrive as humans. Some medical research groups have even used this pyramid to talk to families about their healthcare needs. I think it's important to point out that poverty and race and ethnicity have effects throughout this model. And while these overarching properties won't be directly addressed today, they play a role in every single aspect of the social determinants of health. Additionally, it's important to recognize that while needs are typically met from the bottom up, in reality, people are between levels and they can change over time depending on their circumstances. So now that we've talked about the 5 domains in Maslow's hierarchy, I think it would be useful to work through a quick real-life example. So imagine 2 different children, both have moderate asthma. It's September, everyone's back in school, allergy triggers are high, viral illnesses are picking up, and they both develop coughing and shortness of breath at recess. They both find themselves with empty albuterol inhalers. Child 1 runs to the school nurse, but the school nurse doesn't have any albuterol available or stocked. The nurse calls mom to bring more, but mom can't leave work and she doesn't have any way to get back to school or the pharmacy quickly. Additionally, the insurance the family uses dictates that they can only pick up albuterol from a pharmacy that's 5 miles away. The child ultimately worsens and they call 911 and the patient is taken to the emergency room by ambulance. Now imagine the same recess scenario, but now in child 2, when he realizes he's out of albuterol, he goes to the school nurse who has albuterol stocked and administers it quickly and correctly. The school nurse calls mom, who has the flexibility within her job to go pick up refills and bring them to school. Symptoms improve with albuterol and the patient is able to return to class later that day. So in this one quick scenario, we're able to see how different parts of those 5 domains are at play here. So economic stability. Mom of child 1 doesn't have the flexibility. She's working 2 jobs. She can't take off work to go get the medicine. Additionally, she doesn't have a transportation available to get it. From an insurance and health access standpoint, child 1 doesn't have access to his medications in a quick and timely manner. And from a built environment standpoint, each school is a little bit different. There are perhaps different triggers at each school, different school nursing availability, and different albuterol stocking policies. So now we'll start going through each of these domains in a little bit more detail. And the first one we're going to talk about is economic stability. And we start here because it largely impacts the bases of the pyramid, physiologic needs, and safety needs. Greater economic stability leads to less food insecurity, less housing instability, and more control over the environment around you. So we'll touch on food and shelter and how they affect asthma specifically. So like I said, financial stability affects where you live, your access to transportation, and it can affect what kinds of foods you have access to. In the past few decades, research has been conducted regarding food deserts. Food deserts are areas with limited access to a variety of healthy and affordable food options. You can see in the map on the right side of the screen some of the food deserts in Indy. In 2019, a survey found that 27%, or 1 in 5 people in Indianapolis, lived in a food desert. And so if grocery stores aren't accessible in these areas, then what is? The answer is highly processed foods like from convenience stores, gas stations, or fast food restaurants. And this is concerning because as we're learning more and more, we are learning that processed foods can make inflammation throughout the body worse. Studies have also found that kids who live in food deserts are 53% more likely to have asthma and other diagnoses of obesity and allergies. A different study found that children in lower socioeconomic households with asthma had better asthma control when they participated in SNAP programs. SNAP, or Supplemental Nutritional Assistance Program, helps family have more access to fresh foods. Other studies have shown that consuming foods higher in antioxidants and vitamins have been linked to protection against asthma attacks. We know that better access to healthy food is better for overall health and likely contributes to better asthma control. Shelter and housing play a large role in asthma control, as we've already learned today. We'll talk a little bit more about the triggers within the home that we've already touched on, but I think it's important to bring up housing stability in and of itself and how that can affect asthma. There are less formal studies on this specific topic. We do know that housing instability can manifest in a couple ways, as A, being truly homeless and living within shelters, or B, could be functionally homeless, where families are moving frequently between friends and families' houses. Having to move or being evicted is expensive and can add to an already financially stressful situation. Additionally, families who have been evicted before or are late to pay rent may be scared to complain to the landlord about structural issues at the home, like water control or mold pests. Other ways to think about it, so housing instability can lead to many factors that contribute to poor asthma control, like increased stress regarding moving, loss of medications and property, like albuterol inhalers, nebulizers, spacers, tubing, all that kind of stuff. You need to take your medicines, and also exposures to new triggers when you're moving. And again, as we mentioned before, the high cost of moving adds to the cycle. So the next domain we'll talk about is education, access, and quality. We'll touch on how education level itself is related to health and asthma education. So we found that the level of education affects health overall. As we know, people who are lower socioeconomic statuses often have lower education levels, and sadly, this can lead to a cycle. So children in lower socioeconomic status, we know, have poor asthma control. This leads to more missed school days, which over time can lead to a lower quality education, and then again, back to this lower socioeconomic status as they get older. It's also important to mention that health literacy is different from the educational level. So health literacy implies that a person has an understanding of how the disease works. For example, understanding the difference between chronic asthma symptoms versus an acute episode. It also implies that a person can navigate the healthcare system, understand things like insurance and how to use prescriptions, and know who to reach out to with medical questions. Specifically for asthma, we've seen that increased health literacy about the disease itself can lead to better outcomes. For example, one study showed that improved parent understanding of the disease when they're using asthma action plans that include pictures. This led to better asthma control and indicates that all patients could benefit from clear and simple educational tools. Here is an example of a picture-based asthma action plan here. Tools like these can help family members understand what good asthma control looks like, and also what to expect when asthma control changes or worsens. Feelings of confidence and understanding of asthma in caregivers has been linked to better asthma control. What this requires is a team approach between the provider and the caregiver. And it's important to take into account the literacy level, expectations, and the culture of each family during clinic visits. Multiple studies have shown that shared decision-making strategies where parents and patients with their providers identify goals and then work together to reach those goals leads to a more successful approach. They found that it led to better follow-up, better asthma control, less steroid prescriptions, and more parental satisfaction. So the next domain to talk about is healthcare access and quality. Access to medical care is also at the base of the pyramid, and it's a basic need. This includes access to healthcare at all points, like primary care, urgent care visits, specialist visits, emergency care, and school nurses. We know that access to stable primary care can lead to increased use of the emergency department. Specifically related to asthma, we know that patients who have access to a specialist like a lung doctor have decreased rates of asthma attacks, increased rates of written education like the asthma action plan just seen, increased likelihood of being prescribed daily controller meds, and increased access to specialized asthma medications like injectable medications. A study looking at minority children in lower socioeconomic neighborhoods found that they were 4 times less likely to be seen by specialists for asthma. The pharmacies in the neighborhoods were less likely to be stocked with the medications they need, and the care facilities close by were most of them were understaffed, and they didn't have the ability to correctly educate families on their asthma medications, which ultimately leads to asthma medication misuse. The next domain to talk about is neighborhood and built environment in which people live. Obviously, this has also affected the social and community domain as well. On Maslow's hierarchy, you can see that this also directly affects physiological needs and safety needs like warmth, rest, and security. These pictures illustrate the effect of place. They depict the differences seen in 2 neighborhoods just 25 miles apart. The top photo is of a street in Gary, Indiana, while the bottom photo is taken at Beverly Shores, just 25 miles away. You can see the stark difference in the amount of traffic, green space, and how the buildings are kept. Where you live affects air quality, access to green space, exposure to violence, pollution sources, the ability to have outdoor activity, and indoor and housing quality. We've already heard a lot about air quality today, but we'll touch on it briefly here. So volatile compounds from power plants and exhaust from vehicles, including ozone and carbon monoxide, can contribute to summertime smog, which is a known allergic asthmatic trigger. Living close to major highways or less than 2 miles increases the risk of asthma, wheezing, and poor asthma control. These are troubling short-term effects, but we also know that long-term, living in poor air quality areas can reduce lung growth in kids and cause chronic lung inflammation. We've already heard a lot about inside sources of air quality as well, but we do know that kids who are exposed to secondhand smoke are 2 times more likely to require emergency room evaluation and be admitted to the hospital than those kids who are not exposed to secondhand smoke. Again, we've talked about this a bit today, but cockroaches, mice, dust mites, and mold are known triggers for many people with allergic asthma. And like we know, many homes, regardless of socioeconomic status or neighborhood, can face these problems. However, families who don't have the resources to eliminate these exposures, this is when this becomes a problem. We know that children who live in homes that are poorly maintained have a 22% higher rate of going to the emergency department with an asthma attack. In addition to exposure to pests and mold, we know that some patients are triggered by extremes in temperatures. So living in a home without heating or air conditioning could lead to more seasonal asthma attacks. And houses that are not ventilated properly could lead to higher levels of viral transmission and increased concentration of irritating chemicals that can trigger asthma. Outside of the home, children spend the majority of their time at school. Many schools have higher amounts of allergen than homes. There was evidence of cockroach on 71% of school samples, and 100% of school samples had evidence of mice. Depending on the school, maintenance and ventilation is going to vary. But increased class size will result in poor ventilation and more exposure to viruses. And as mentioned earlier, not all schools have the same amount of school nursing available and albuterol stocked. We know that areas with natural vegetation, like parks and street vegetation, have been shown to have numerous health benefits for the general public. There have been some inconsistent results with regards to asthma in studies in this area. Living close to green space could offer benefits against developing asthma and allergies if the exposure is done when you're young. However, as you get older, it may not be as beneficial because the immune system and allergies have developed, and there may be just another source of allergen exposure. One study showed that living close to a green space had mixed benefits, as it improves access to social interaction and exercise, but could also be perceived as unsafe in some areas. And this last point starts to overlap with the importance of community and social context in asthma care. And that's the last domain we'll talk about. So community and social context. So once your basic needs of food, safety, and shelter are taken care of, psychological needs are the next level. So this includes both sense of self, relationship with others, and I have it also including the orange box for safety and security, as they can overlap. It seems obvious that strong family support would be protective against asthma symptoms, but one study was actually able to illustrate this. The graphs on the right side of the page show that high levels of neighborhood problems and low levels of family support are associated with more days of asthma symptoms and poor lung function. They suggest that a higher level of, quote, family chaos could lead to these findings, as it may be harder to accomplish goals like finding and taking medications on a regular basis, or the inability to establish a routine. Looking at it through a little bit larger scope than just the family unit, we know that communities that have strong support systems from within are able to utilize their resources and feel empowered. Strong communities also offer a space to reach out to peers and help for advice. Organizations like the Neighborhood Asthma Coalition and the Asthma Coach programs in St. Louis work to address the psychosocial issues that contribute to poor asthma control, and they consist of the members of the communities they serve. It's important to consider communities that have historically been marginalized and disadvantaged, like immigrant populations and the LGBTQIA youth. There have been 2 studies that suggest that asthma prevalence is actually higher in women that identify as part of the LGBTQIA community, and this could be linked to higher amounts of anxiety and stress that's also seen in this community. That leads us to our next topic of asthma and mental health. We know that children of parents with depression have higher risk for poor asthma control. We know that infants of mothers with high stress levels during pregnancy are more likely to wheeze with illness when they're infants. We also know that as childs grow up, mental health disorders like anxiety, depression, and ADHD are up to 3 times more likely in patients with asthma, and more severe asthma symptoms are linked to higher anxiety levels. This chart over here is taken from a study that looks at people with more severe asthma and less severe asthma, and you can see that the rate of mental health disorders is higher in the moderate and severe asthma group. We know that stress changes the inflammatory response in the body, and that's important because that sometimes affects how steroids actually work to treat asthma. So our typical medicines that we would use might not be as effective in people who have more anxiety and depression. Kids who live in areas with higher levels of violence have measurable changes in the biological stress markers in their blood and have higher scores on their mental health screens. In this graph, basically it shows that people who live in more violent communities are depicted with the darker bars, and the vertical axis represents number of nights with asthma symptoms. All in all, this graph shows that even when you take into account race, ethnicity, socioeconomic status, history of negative life events, certain behavior and stress, children who live in those more violent neighborhoods will still have more frequent asthma symptoms. And caregivers for children in those neighborhoods with higher rates of violent crime report higher rates of worrying about life events, less outdoor play, and more frequent asthma symptoms. This, along with the mental health data that we just talked about, suggests a connection between stress and asthma. So we've talked about a lot of things, and you might start asking yourself, what can we do about all of this? It's a pretty big question. And it's definitely intimidating, right? It's overwhelming to think about how to start tackling this. And I think that the easiest way to approach it is to just start simple. I think simply considering and identifying these determinants of health during your interactions with asthmatics is the best way to start. So you got to recognize that many of these things that we've talked about today, they're outside one individual's control. And a lot of times these are the factors that may explain why a patient does or doesn't make it to clinic appointments, use their meds correctly, or ultimately achieve good control of their asthma. A lot of these things aren't just visibly apparent when a patient or person comes to see you or talk to you, but they become identifiable the more and more you listen and talk with the patient. So we always like to just listen and then listen some more, and then things will kind of come out, and that's as you keep listening. And then lastly, it's important to get to know the resources in your own community. So what kind of strategies from an education standpoint can we do to start combating this? We've been able to identify some ways to combat these many factors that contribute to poor asthma care, poor asthma control. And we encourage our patients to educate themselves and their families about asthma. And as providers in many clinics will screen for those risk factors like mold or allergens during a clinic visit, and then can provide that education during the visit on how to decrease exposure and possibly remediate the problem. In the clinics, when we are educating patients, we try to use a 5th grade reading level and lots of pictures so that people of all reading abilities and languages can learn about their asthma care. And we try our best during each visit to identify each clinic's individual barriers. And again, that goes back to that listening component. And schools can assist by advocating for stocking albuterol nebulizers and spacers within the school. And there are some partnerships and strategies between schools and healthcare providers so that we can treat kids more appropriately and keep them in school as much as possible. Another thing we can do is just learning more about the type of insurance coverage available to the people with asthma. So being familiar with these policies can help avoid lapses in coverage. And I'll admit this is something that we work on as healthcare providers every day, and it takes a lot to stay up to date on these policies. And then we can advocate for policies that make insurance more accessible to everyone. We can work to educate school nurses and other personnel about the symptoms of asthma and how to use albuterol correctly. Outside of the medical field, we can encourage people to sign up for community health worker training. And a community health worker is someone that could be like a school counselor or administrator, or perhaps like a church volunteer who acts as a liaison between the communities they serve and the healthcare system. So this is a map here on the screen showing albuterol stocking laws across the US as of 2019. As you can see, Indiana is highlighted in purple, which means that we do have legislation in place to allow for albuterol stocking within our schools. How the legislation is worded is that it allows, but it does not require. And then air quality, again, we've talked about this a little bit today, but some things you can think about to learn more about air quality. There's a great resource called Nozone, and Nozone is an organization that can help notify people when ozone and pollution levels are high in the area with like a text or a notification on their phone that can then encourage them to stay inside that day and avoid triggers. And it's also helpful to learn about as many local policies as you can, for example, burning policies, asbestos policies, and how to report. Knowing how to report any of these concerns is also a good thing to know. Advocating for things like smoking bans in multi-unit homes, upgraded ventilation in schools, and safe outdoor green spaces in our communities are small ways that individuals can help improve air quality. Some communities already have resources and strategies in place to improve asthma control through home remediation and weatherization. Here at Riley at the High Risk Asthma Clinic, we have an active partnership with the Healthy Homes and Health Department that can help provide legal support to families to help keep their homes clean and up to date. The weatherization efforts can help decrease leaks and gaps and improve energy efficiency and decrease water damage that can lead to mold exposure and pests, as we've already heard. Strategies to decrease pest exposure should be low cost and avoid chemicals, like we've already said. As I was learning more about this, the Indiana Weatherization Assistance Program, I think that their website offers a good place to start for people who are looking for resources into this. And then, individual strategies to address the feelings of safety, belonging, anxiety, and depression, I think mainly include being aware that mental health through all of these things listed, like violence, emotional instability, trauma, parenting, grief, all that stuff can affect our mental health and then affect our ability to control asthma symptoms. So just being aware of that and being aware of the resources within the community. As providers, we definitely, advocate for screening these patients within the clinic to identify these stressors. So to briefly summarize, the social determinants of health have a large impact on every aspect of asthma care and management. And the 5 domains are connected and they're overlapping. And being aware of identifying different aspects of the social determinants of health in people with asthma is important to understanding how to best treat each individual person. And within each domain, we've identified some actionable ways to improve asthma care. And while it seems overwhelming to focus, on everything, I'd say just focus on the things that you know that you can do today and do something about. And with that, I'd be happy to take any questions. I want to say a special thank you to Drs. Nadia Krupp and Kirsten Klepfer they helped get me involved in this conference and helped to mentor me through this presentation.
Thank you so much for that. That was amazing and so informative. Do we have any questions? We have a little bit of time until breakout session 3. So please feel free to ask questions at this time. About 5 minutes. And I just want to call everyone's attention to the chat. Lisa posted a link with a resource for schools if they need funding. Funds and resources. So thank you for sharing that, Lisa. Any questions? I agree. Fantastic presentation. Thank you so much for being here. Dr. Averill, I'm sorry for mispronouncing your name earlier.
It's an easy one to mispronounce, isn't it?
It is. It's not a problem.
Dr. Averill, I had a question for you.
Sure.
Thinking from a coalition standpoint, do you have any ideas how we might address some of the social determinants as a coalition? Because, this presentation, I think it's really valuable to the work that NJAC is doing. And it really, it affects all types of health conditions, but
yeah, I think that everyone here, obviously as part of the coalition, is probably, if they weren't, and they're probably kind of aware of a lot of the things that I've talked about today. And I think that advocating it, I think the coalition probably has a greater ability than the average, say, physician or person to advocate from a legislation standpoint to address some of these things. And I would say just like picking one at a time is probably, and like kind of would be an easier thing than trying to tackle everything at once. And Dr. Krupp can probably also speak to other things that the coalition has more of an ability to do. I've definitely learned a lot about the coalition as I was preparing for this, but this is my first meeting, so hopefully I learn more.
Thanks, Dr. Averill. We really appreciate it. That was great. And I think from one of the biggest things that NJAC does is that it helps to connect, say, people who are doing some of this work in one part of the state to people who are interested in doing it in another, or people whose work is complementary to each other. So let's say, for example, that so one person is working on housing remediation, but they still have water intrusion issues. Then somebody else is working on weatherization. And so once you get both of those people involved, then you get a much bigger benefit to that individual patient. And so this coalition is really good at being able to connect people like that who are, whose work can then make each other's work better and more effective, if that makes sense. I can prescribe all the medications in the world, but if we don't have the environmental component or the mental health component or the financial component, then we feel like we're kind of on a hamster wheel and not really getting anywhere. So that's what this coalition really does well. And there are certain things that we can continue to advocate for on the state level too. Things like air quality and clean air indoors, decreasing people's access or decreasing people's exposure to tobacco smoke, improving ventilation, things like that. So, and educating people about what we can do and how effective it could be. So, yeah.
Thank you. Any other questions, comments? We have a couple of minutes left. All right, I am going to post some links in the chat for the next 2 sessions. And just a warning, we do have to end the Zoom first before the next breakout sessions can resume. So if you lose these links, you can also access them from the email that was sent about 9:45 this morning with the agenda. Those links are clickable and should be super easy to get to. So if we lose you, please join us for one of the other sessions using those links in your email. So thank you so much again, Dr. Averill, for your presentation and for the information. And thank you everyone for joining, and we will see you at the next session.